I am very pleased to thank the organizer, especially my friend, Professor Hardin Shah. Having said this, a very excellent program, continuing every week till the December. He will take the nutrition science people in Asia close together and having the spirit of doing a real-time conference, going to different countries. And I have gone through the program. It's very impressive. So I congratulate him. Also his colleagues that are the nutritionist in Indonesia, taking that. He's our president of the nutrition societies of the Asian countries. So Pence president. So I share uh, things with him and be very proud of it. It's a very august session. Now, according to the advice of the master of ceremony, I go to the presentation and let me present some of the facts and figures of Bangladesh. Thank you very much. This is a topic is the program on micronutrient deficiencies and stunting in Bangladesh in this second international symposium of Bangladesh. In the first picture on the left side, you can see the dark color, red color. All these are highly stunted children population in the north of Bangladesh and in the east of Bangladesh. But on the bottom on the left side, of the west of the Bangladesh, you can see very less. This is a distant peripheral area of the country as well as a hilly area, top and the right side. So there is a difficulty in access as well as a flood comes through the north of this country. So that also a washing effect. So there are different risk factors there. So, and opposite to that, we have the more than half of the people, 60% people, children are not stunted. So in the right hand side, you can see that there are the sources of micronutrients and nutrients that would be reducing stunting through our national and local food. Next, please. Next. Our constitution of the government of Bangladesh shows that the article 18 shows that government will protect the nutrition of the countries. And accordingly, the government has taken up the ISFAN 2 declaration on the proper health, food, agriculture, environment, and education, etc. And with a multi-sectoral approach in the country. Next. So micronutrient deficiencies define that which of the nutrient requirement is a less than 100 milligram per day per person. And by that definition, about 2 billion people worldwide are suffering. Most prominent deficiencies on micronutrient in Bangladesh is vitamin A, iron, iodine, and zinc. You will see later on the results. And to achieve it with the SDG, this remains a challenge. Next. This is the 6 month to under 5 children. They are in a micronutrient deficiency. About 8 years back, we had the national survey. And you can see the left-hand blue color is the total national picture. And you can see the tall columns, zinc and vitamin D, more deficient. About half of the children are deficient in that. And we can see that the urban, green one is the urban one. There is a somewhere close ties with the rural area. Red is the rural. And you can see the rural area zinc deficiency is very high, vitamin D deficiency is high. Slum is the most sufferer. And I can tell that 10% of the population of Bangladesh are in this group of slum. And about 30% people live in the urban area. So we can see the other deficiencies are not that much except vitamin A deficiency. And all in slum is very high. So we have to see that the calcium deficiency is also noted in the national level and in the rural level. Next. This is the next group of children, 6 to 14 years. They are suffering from the micronutrient deficiencies. There is quite a 1/5 having a vitamin A deficiency. For about 40% average is zinc deficiency. And vitamin D deficiency about 45 to 60 in the slum. Calcium deficiency, as you say, below 20% average. Next. You can see the mothers, non-pregnant, non-lactating mothers, and in their case, iodine deficiency, vitamin D deficiency, and zinc deficiency comes out to be very, very prominent. And others are not so prominent in this group. Next. This is the UNICEF picture. They have drawn like this. The deep color goes into very high level of stunting children in the world, in most of the Africa and Latin America. Some part is in India, Bangladesh is a 20% like that. But actually we have little more. And they have said that during growing up, this food are not much available. Education is defective. So one of this child is not able to, professional life is affected, and the vicious cycle goes on so that the stunting continues. Next. This is our picture of 2002. You can see that we are now here about 29. So it is about a very high level of stunting that we had to start in under 5 children. They have reduced significantly, and we have a projection. If that goes on, we will meet the SDG level in 2029. I hope that we can do faster than that. Next, please. This is a picture that we had 54% stunting in 97, and it about 9 now is about shows 28%. So we have about here also clearly shows that we have reduced 50% over this period of about 22 years. So this is a slow growth, but 2% reduction per year. I think some countries also have similar picture. Urban, rural, you can see the rural area is higher than urban in stunting in Bangladesh. Next. So the policies that are on place on micronutrition in our national nutrition policy, this is very good policy you can see in the website, and to have it has covered also all citizens by the age groups, children, adolescent, and pregnant, lactating mothers. Next. These national policies ensures the says the ensuring food, safe and quality food to promote healthy feeding, strengthen nutrition specific programs by the government. We are having that now. Nutrition sensitive program, we are also having that in the country, and multi-sectoral. Definitely this is a multi-sectoral issue, and financing such programs. Next. Nutrition education program, that is in the food policy, that was developed mostly by the joint effort of Ministry of Food and also Ministry of Health. And in the food policy, they have also taken the step of popularizing the idea of balanced food, and is a formal, non-formal education to the population. A step for communication of the dietary guidelines on the balanced food in the media. China has called several dietary guideline meetings of the Asian countries. 2-3 I have been invited and attended. So the dietary guideline we are trying to preach through our different public health education program. Communication has been given importance, and the dietary habits modification. You know, we have a high level of diabetes and obesity, all coming through the wrong habit of taking too much rice, carbohydrate foods. So this needs to be told to the common people how to change that. Also the rich people not to take that too much rich food. Next. This dietary diversification, you can see the picture, Bangladesh very abundant. I think 4th, 5th position in the world on production of vegetable and fruits. Similarly, the poultry production is very high. So we have a lot of sources of animal and vegetable origin of foods. So we are trying to have in the policy that encouraging home garden and this food intake by all the people and awareness building. Next. There is a effort of the salt fortification with iodine, and the this is the wheat flour fortification with the iron and other micronutrients, and this is a national program. Next. And we have the National Nutrition Service going on from 17 to 2000. Previously 10, 15 years we have run this program, 5-year program in the country to improve nutrition. This is one thing very particular. Money is assigned for 5 years and we spend in different direct programs. This is very important. And we can go to the content of this next, please. This is the Honorable Prime Minister who is really giving vitamin A to the children. This is the then Prime Health Minister. So they have encouraged the food-based approach initially, everyone, but side by side vitamin A supplementers is also going on in the country twice in the year. Next. So this is the one of the very high official additional secretary of health. She is giving the orientation of the iron and folic acid supplementation and also updating national strategy of the anemia prevention. We have done that, and awareness building among iron folic acid supplementation is also going on for all this national program. Next. Zinc supplementation has been around diarrhea and long time. I have worked in this area during my PhD in before 90s. So government has taken it up in the whole country. WHO has suggested it for the diarrhea. So all the health facilities are getting zinc supplementation free during diarrhea, and it also prevents diarrhea. So in your country, you can also try that. So we are also collaborating with other health program like IMCI. Next. So vitamin D supplementation is not doing that. Salt iodization I have told earlier. Next. So food fortification is going on, like oil is getting vitamin A fortification, and we are doing to spread it throughout the country by all the media that is possible and providing technical support to the industry. Next. This Honorable Prime Minister has opened 2009, 2010, 11 and 14. And she has also come and opened these books for the complementary food. So breastfeeding has been really streamlined, our Prime Minister. Salute to her, putting the example in the world. She came 4 times to encourage us. Next. She gave the landmark directives, and the IUICF, IUICF practice is a very high level in this country. And my friend Hardin Shah was asking what is the exclusive breastfeeding rate here. In Bangladesh, I told it is 65, and they have got 40 in Indonesia. Actually, 40 is the global average. So in all indicators, Bangladesh IUICF is a very progress because of the government program and government support, including the implementation of the BMS Act. Next. This is you can see the adolescent education, and they have been given encouraging food stuff, books on the adolescent nutrition, this complementary feeding. This is how mothers are demonstrated with their local food. Homemade complementary feeding has been our main strength. Oketani management of the Oketani lactation management has been evolved from Japanese. We are collaborating with them. This giving problem solving for breastfeeding difficulties, and this is going on through the government hospitals throughout the country, and we encouraging homemade complementary food. Next. This is the Honorable Prime Minister unveiling the complementary feeding recipe book in Bangladesh. Next. Growth monitoring and promotion, this has been given important with a deworming program, and we are doing the advocacy orientation in the country level. Next. After growth monitoring, we are giving good hygiene practice and giving training to the program. This is a government program going on throughout the country. Next. This is the Agriculture Ministry. They have taken a lot of initiative of vitamin A fortified vegetable growth, zinc containing rice, diabetic rice, beta carotene containing sweet potato. You have got this orange flesh potato, golden rice with beta carotene, environment friendly green super rice, iron containing rice, home fortification rice with lime. So all these are the Agriculture Ministry for. Next. My summary will be that our government of Bangladesh is highly committed to the improving the nutrition and reducing stunting in this country. And progress on improvement is satisfactory to some extent, but lots of challenges are there to overcome the malnutrition. Our policies and programs are already in place. We need a strengthening of the implementation and more collaboration and multi-sectoral approach in our country. Learning from your countries, the international areas will be helpful to Bangladesh. Thank you very much once again, Professor Harding Shah, for this good initiative.
Good afternoon to everyone. It's certainly a pleasure to have the opportunity to be here or being invited to join in this interesting video or virtual conference. Well, let me try to manage my PowerPoint first. Right. Yeah. I hope it's on the screen now.
Yeah.
Right. Thank you very much. Yeah. So, I mean, certainly, first of all, congratulate Prof. Roy for helping me deal with the introduction. So I think in my talk, I probably will go into specific things that I would like to share from Thailand. Therefore, my outline, I would like to start with the stunting issues. And as some of you might be aware that Thailand has been one of the countries which have been very successful approaching the nutrition problem through the community-based program, starting with the under 5 as a focus. And certainly today I'm just kind of covering that and try to focus on stunting. Then I would like to talk about other micronutrient programs. The key ones are the one on anemia during pregnancy and reproductive age women, as well as that for children. And of course, iodine problem remains in most countries. And as you all aware that, you know, iodine is very limited in food sources. So the program in soil iodization probably would be the one that I give some focus on, as well as inform about the iodine supplement during pregnancy. As I go on talking about each of these problems or situation, I would try to give some synthesis or lessons based on some of the program experiences, as well as also try to, I like to raise some comments around the data that help us to understand the kind of progress made from implementing various programs. I like to begin with this diagram. I hope it's not too complex if you follow me. Thailand, as I said, have been known of implementing the program from the community-based approach, whereby at the community level through the primary healthcare movement, we have created the kind of village health volunteers and also the some kind of organization of the community resources network, and to start doing or joining or participating in the efforts of trying to improve the nutrition status of young children. So the basic tool at the time is really the growth monitoring to help identify the problems. And then with the help of the frontline personnel in the 4 main sectors, the causes of the problem were analyzed, and then the plan or community action plan could be made with the support both in terms of technical, but in terms of the resources, some of them come from the community itself and some come from the government. And as these actions evolved, at the beginning, it was really a lot of challenges, a lot of struggle. and simply because try to integrate the resources from the community and from the government all together. And I think it has taken a couple years until we start realizing that, or as we all know, that dealing with malnutrition cannot be any single direct interventions. So we did a small research to begin with to develop a kind of holistic set of indicators and criteria, which is called the basic minimum needs approach. And if you look at the box on my right hand side, you can see that nutrition is one listed, but along with that also the basic health services, the water sanitation, in agriculture in terms of food production, income generation, and so on. So this has broadened the scope of dealing with undernutrition beyond just doing direct nutrition intervention. In other words, we have included the nutrition sensitive interventions all along from the beginning with the capacity of the people in the community themselves, and with the support from the health frontline workers, frontline personnel, whether it being health, education, agriculture, and others. And this is a kind of dynamic bottom up and to the top down, in the sense that the action actually happened at the bottom, but up there at the planning, policy and planning level, we certainly already have the multi-sectoral body who help to oversee how to allocate the resources in order to fit in with what is needed at the community level. So this is a sort of the summary of the whole dynamics put up by Professor Graiti Tansisirin, who many of you know. So I think this is a very important diagram, which was a synthesis out of our experience, seeing that the government need to understand the need for some kind of multi-sectoral interventions and provided the support to the community. At the same time, there must be the mobilization at the community level. In our case, it's the village health volunteers, which were trained in the ratio of 1 to 10 households. And with the tool like basic minimum needs indicator and actions along with this, which you can see on the left side, which are the menu of activities. If you just think about the intervention listing, I don't think this is so different from any countries. But I think the key is that what is the kind of mechanism, what is the kind of process which will make the implementation of these components effective. And in case of Thailand, I think this is what have been happening since 1980 at the beginning. And as I said, it took a few years for things to get established. And then from then onwards, at the time, we used growth monitoring to monitor the situation, and growth monitoring was done totally by the village health volunteers who take the weight of the children. At that time, we had to decide to just go with simplest indicator. So we used underweight to begin with, because we didn't have a lot of resources to invest and in not only the equipment, but training and so on. But that actually showed us the trend that with the implementation starting around early 1980, within 5 years, you could see that the moderate and severe undernutrition declined significantly and continues so until today, actually. So the data that is available show this very nice declining trend. But at the same time, we start having some surveys and including stunting, underweight, wasting. So you can see that the first national representative data, which is based on the WHO growth curve, show that we did have very high stunting and underweight at the beginning in 87. So it's somewhere around the first 5 years of the community-based implementation program. But since then, we see drastic decline in the rate of both stunting and and underweight. And that prevalence or that rate seemed to be kind of sustained, although, it's recognized that somehow it stay in the magnitude of 10–15%. The point also to add is that severe undernutrition seem to not exist, although we recognize that at some point, somehow wasting remains the concern here. As you can see that from the 3 mix survey, we seem to have the prevalence of wasting, which is still above what WHO recommended of 5% as not being a public health problem. So to summarize in terms of the lessons learned on the stunting, on the policy and the implementation side, it's certainly important to have the interface of the macro and micro level planning, which we introduced poverty alleviation policy or plan, which help to streamline the resources with the focus on the poverty-stricken areas. And that way, we have some concentrated efforts in those most vulnerable areas. At the same time, with the primary healthcare movement, with the village health volunteer and the community to mobilize the community resources and then watch over their own children and mothers. So the community-based actions really were carried out by the health volunteer as well as other members in the community. And so by the time we have the BMN that helps to both monitoring the situation as well as is helping people to be able to decide on what actions. And then working together with the multi-sectoral team of the frontline personnel of the key sectors was really important to facilitate all the actions that was happening in the community. Specifically on the growth monitoring promotion, which had been done quarterly. In the first 2 decades, almost the entire effort in terms of carrying out the growth monitoring was done by the health volunteers using the simple weighing bar scale and growth chart to plot out what is the percentage of prevalence of underweight, as I showed in the previous slide. Other aspect is the village processing supplementary food or complementary food in the present term that could be done at the community level. And there is a lot of interesting thing evolved from this example. But the key thing is the learning of the people of how important the complementary food is for small children. And of course, various messages of the nutrition education went along partly by the health volunteers and also supported or also with other public awareness program. After the year 2000, when the situation has improved significantly, at the time it was then decided maybe we really need to include the height measurement into the program aside from the weight. And at present, what we have done is, I should also mention, as we come along, the health system have improved in terms of the outreach as well as in terms of the types of services and outreach to the people. So at present, the children under 2 years attend the Well Child Clinic at either at the health promoting hospital. You can see that this is actually the health center in the sort of the setting in most countries, but we upgrade that both in terms of personnel and the facility in order to do better in terms of promoting health. So the Well Child Clinic can be set up at that level as well as at the district level. As a main platform for people to attend. And then any children who miss out were notified to the health volunteer to follow them. For the after 2 years or 2.5 years, around that, up to the primary school levels, growth monitoring and lunch, and in some places also breakfast, and also the milk program have been made available to the community daycare centers or schools. In Thailand, I think the spread of the schools, primary school, is really quite widely, and the daycare center even was established much later. I think at the moment it exists in almost the entire country in terms of at the community level. Challenges, certainly we still have that. As I said, we noticed that stunting declined significantly in the early time, but somehow it stayed around 10 to 15%, although we consider that mild. But I think it's very important to find out. And I think moving from the weight-based to the include the high-based approach is very important, so that we look at how to shifting from dealing with malnutrition to try to promote the optimum growth in a sense. As I mentioned, the wasting is still above the public health criteria, so we need to further investigate what are the causes. In terms of the diets, especially in the lunch program, which some of them have been combined with the food production at the school or even community, this has been successful in certain areas, but I think many places there still need some improvement. Of course, effective counseling, we kept talking about that, but I think, this is a kind of never ending, because I think as time goes by, we have better knowledge. We have a better ways of how to make the messages more succinct, more clear, and can communicate to the people easier. So the IYCF at the present continue to be important, whether it's breastfeeding or complementary feeding. But on the maternal side, which used to be more like, monitoring just weight gain during pregnancy, I think it's very important to keep more emphasis to the pre and periconceptual stages of the pregnancy, because I think, as we know, in the developmental origin of the problem, I think this become very important, and we really need to find a way to better communicate in the counseling. At the same time, we cannot forget the fact also that while undernutrition has declined, somehow overweight and obesity has been rising. And in our case, we start seeing that. And at this point, it's around 10%. So I think it really requires more effective intervention. And lastly, on the data, as I presented previously in the slide, the data from routine surveys tend to underestimate the prevalence, although the large scale would have been better in terms of giving us the correct magnitude of the problem. But it certainly is costly and sometimes also needs some technical support. Now I move on to the micronutrient program for women and children. I group them into three aspects. The first is on the health sector base. As you can see that as in many countries, we have daily supplementation for pregnancy and for lactation as well, if they continue breastfeeding until 6 months. The preparation that we use in the supplementation contains 3 micronutrients: iron, folic, and iodine, which is called trifodine, and given to the women who attend ANC, which at present the coverage is over 90%. Although the compliance is not well monitored, we're still struggling with how to do that. Secondly, is on the weekly iron supplementation, which is included in the universal health coverage, especially for infant and preschool. Iron syrup was distributed at a Wellchild clinic, while the iron folate tablets are distributed to the school kids. We struggle still with adolescent and female workers, because this, especially the older children and female workers, they are not part of this UHC coverage. So we really need to work on what is a better delivery channel, whether it can have some, private sector involvement, for example. Now, the second group of intervention are food fortification. Certainly, Thailand do not have so many food fortification programs, but the major one, and I would claim to be quite successful, is the salt iodization. Although it started a long time back, the universal salt iodization was just mandated in 2010 with the iodized salt content of 30 ppm. But what is very important is to also have the quality assurance system set up along with this promotion. It's also well known that in Southeast Asia and Thailand, the condiments like fish sauce or soy sauces are also commonly used, not only salt. So that is also mandated for having the proper concentration of iodine fortified, and also in the animal feed. At present, the household coverage of iodized salt has increased from only less than half in 2006 up to about 73% in the recent years. We have the monitoring system for looking at the urine iodine of pregnant women done by the Ministry of Health, and also the survey every 5 years for the children 0 to 14 years. Other fortification, which is also mandatory, is vitamin A and D in the sweetened condensed milk. This is not to promote the product, but for a long history, because some of the poor mothers use it for feeding the babies. So that is a kind of, to prevent severe problem. So it was introduced. And some other voluntary fortification by the private sector, which is not really mandated by the government. The last group, which I think is quite important all along, and Thailand has started from the beginning of trying to promote the food-based approach. And in recent time, as many other countries, each country developed now the food-based dietary guideline, including in Thailand that we started with the nutrition flag for the general population. But later we used a computer program called OptiFood, dealing with the data from the food consumption survey, in which that way we can account for the actual food patterns, so that the recommendation for the specific group like infants, young children, pregnant and lactating can be made to ensure adequate intakes of several micronutrients as a whole diet rather than as promoting individual micronutrients. And then these information are used to modify the food-based dietary guideline. In terms of monitoring surveillance, certainly some we still rely on the routine report like the anemia, and the urine iodine for iodine deficiency also in pregnancy from taking sample from the women attend the ANC. Although the national representative survey also include anemia in the reproductive age women, but not in the pregnant women. And for children, unfortunately, we had to rely very much on a lot of periodic survey. We don't really have a routine reporting system for that. But just to show again that the prevalence of anemia seemed to be declined very fast in the 90s, from the 80s to 2000. The most recent data reported of 17%. But when we look at the national survey of reproductive age non-pregnant, we did see that women reproductive age still have the prevalence of around 20-25%. So in other words, this confirms again that the routine reporting data of the pregnant women might have been somewhat under-reporting. Worse is that we did not collect the data. We had the data, but they are not reported when it close to the childbirth, whether the anemia is still highly prevalent around that time. In children, as I said, there was one effort trying to measure at the school entry, and this is across the administrative regions in Thailand. So you can see that in most regions, I think this in 2014, the prevalence remains quite high, around 20, 25 to even 40%. For young children, what I like to highlight in this slide, this is from the CNAT surveys. While prevalence of anemia were at 26 or 40%, depending on whether urban, rural. If you look on the right-hand side, here is the prevalence of iron deficiency anemia seem to be relatively low comparing to the prevalence of anemia. On the other hand, iron deficiency without anemia seem to be high. So in other words, this seems to tell us that somewhere, somehow, iron deficiency at the milder degree exists in a large proportion of the people. And also, we have to recognize that iron is only one cause of anemia. We have population who are hemoglobinopathy carriers. We still have somewhat the parasitic infection and so on. So the problem anemia cannot be eradicated just to do iron intervention alone. And this depends on the country, have to identify what are the key causes. I move on to look at the data on the urinary iodine. This is a median for the pregnant women, as I said, collected from the ANC. It showed that over time, we seem to stay in the range of being mild to moderate iodine deficiency to the adequate level, depending on the region in the country. And it's clear that Northeast seems to be worse off. However, when we look at the data on children, they are all above the median of 100. And in sometimes they even went towards a higher direction. So we need to keep a watch out on this to make sure that it won't go too far, as high as something like above 300, which is considered excessive iodine. Now, putting together the data from this survey, we also recognize that somehow multiple micronutrient deficiency exists, although the magnitude is not very high. But somewhere around the subclinical level, I think we still do have either one or more than one problems in the population of children. So to sum up the program in micronutrient, in terms of the health base, I think the daily supplement is doing better and better, although we don't really have a good coverage and compliance reporting. The weekly supplementation, the coverage is not as high, but the delivery channel, as I said, remains a challenge. And lastly, we need to recognize the multiple causes of anemia, so that we would introduce a proper set of intervention. In terms of food fortification, I think it's really important to continue using the USI as a main strategy to deal with iodine deficiency with a good quality assurance system and surveillance of the IDD in most vulnerable groups, meaning pregnancy and children. Recently, Professor Zimmerman raised the question of the need to supplement during the pregnancy in situations where we have mild to moderate IDD. And this is actually one of the studies that we have done as well. So we'll see whether this policy will be changing in light of the improvement of the situation. And lastly, on the food base. Sorry to put this the last always, but I think the diversity of the diet is very important, especially in our case where the deficiency seems to be mild. So rather than going with the supplementation, we probably have to deal more with the diet. And the diversity is a key issue here. Whether we need to do better in terms of counseling education, whether we need to strengthen the food agriculture system in order to provide availability, accessibility, and affordability of nutritious food sources, including some indigenous sources. And finally, on the indicators, as we know that in children, we do have the diversity indicator, but we haven't done in the other age group, and probably that will help to monitor in another important target group. So with that, I would like to end my presentation, and thank you so much for your attention. Thank you.
Thank you very much for the introduction. I'm from China. My presentation topic is about the programs for controlling micronutrients deficiency. And stunting in. Okay, there are three parts in my presentation. The first one is nutrition status in infants and young children. Second is health and policy and national programs. And the third, I will give an introduction of a nutrition project, which is named Yanbao Project. So first, let's see the nutrition status of young children and infants. They are facing a double burden of under and overnutrition, I think like other countries. The overweight and obesity on the rise and micronutrients deficiencies are prevalent. Stunting greatly improved in recent years, but still in high prevalence. Regional disparities observed in the nutrition status of young children. For example, the stunting and the anemia are high in rural areas compared to the urban, whereas vice versa for the overweight and obesity. I listed three figures from national monitoring data. So you can see the first one, which is about stunting prevalence. You can see the red lines, which resembling the big city. You can see it's very low. It's lower than 5%. And also you can see this line, it's quite high up there, which shows the poor rural regions. You can see it's quite high. It can be high up to 25%, somewhere about that. I should point out is that after 6 months, you can see it's dramatically increased. And this figure shows the anemia prevalence in poor rural regions, 60.4%, in the urban region, 9.3%, in the whole country, 11 somewhere. And also you can see the obesity rates. It's after born, it's somewhere about 6%, then decreased dramatically until 2 years old. And then it's remain low rates, but you can see the differences between city and rural. The city is higher than that in the rural. I have data for vitamin A and vitamin D here. Vitamin A includes deficiency and marginal deficiency. In urban region, it was 22%, and in the rural region, it's about 37%. Vitamin D includes vitamin D deficiency and inadequate. You can see in urban, it's even higher, 56.3%, and in the rural, it's also quite high, more than 40%. Some studies reported highlighted that the inadequate intakes of some macronutrients such as calcium, zinc, selenium, thiamine, and riboflavin amongst Chinese children. The prevalence of inadequate calcium intake should listed the top inadequate, which I don't have the data for the very young infants and young children, but I have data here for 11 to 13 years old students. You can see the inadequate prevalence is about 100%. And for iron, it's somewhere about 10%. Chinese government attaches great importance to its population health. In recent years, there released 3 major nutrition and health related policies. The first one is Outlines of Healthy China 2030, which is released by the central government in 2016. In this policy, the government tries to tell people that without health, there is no welfare society, no well-off society, and there need a shift from a treatment-centered from a treatment-centered approach to a health-centered approach. The government also wants to incorporate health into the common responsibilities of all levels of government. And the policy also includes all details of the National Health Development Plan. The second policy is a National Nutrition Plan, which is released in 2017. This is an implementation plan for Healthy China 2030. It's put forward the national nutrition goals plus 7 strategies and 6 actions for nutrition development. And the third policy is about the Healthy China Action Plan, which is also released in last year, 2019, which is also an implementation plan for Healthy China. And it contains majorly 4 parts: comprehensive intervention of health factors, maintaining full life cycle health, prevention and control of major diseases, organization and implementation. I listed some the goals of national nutrition plans, which divided into 2 parts. One is should be finished by the end of 2020, and another one should be reached by the end of 2030. You can see it includes anemia. For example, the children under 5, anemia rate should less than 12%, and other for pregnant women 15%, for elderly people 10%, and for the people in the rural regions 10%, and folic acid for pregnant women, the rate should less than 5%, and the rate of exclusive breastfeeding rate should be over 50%. Stunting rate of children should children under 5 years old should under 7%, and it also requires the whole country narrowing the height gap between urban and rural students. The rise in obesity rates among students should slow down. Increase the rate of nutrition screening for inpatients and proportion of nutritional treatment for malnourished inpatients. The awareness rate of residents' nutrition and health knowledge should be increased by 10% on the current basis. I'm not going to read all of the goals for 2030. So you can see there is detailed goals established by the government. Within the National Nutrition Plan, there are 6 actions, as I mentioned before, but 3 of them has related with the infant and early young children. The first one is the first 1,000 days of life. You can see there are some projects within these actions. For example, the nutrition guidance and assessment, the intervention plans, nutrition intervention of infants using Yin Yang Bao. I will later describe this a little bit detail. The second action is nutrition in schools. For example, some projects will within these actions guidelines, receipts provided to the schools to prepare balanced nutrition meals and others. So, for example, the overweight and obesity of students control. And the third action is nutrition in poor regions. There are some other projects launched by the government should cover of these actions. Another thing I need to point out is about a system which is well-established maternal and children health care system. So Chinese government has continuously established this system for years, and the infants and young children can get medical and health checks for free in order to promote the nutrition and health. You can see the coverage of this system has reached recent year quickly. It's generally from somewhere about 80s to more than 90s. Now I'd like to give a brief introduction on Yangbao project. Yangbao is a product. It's a complementary food supplements, which is a soybean-based micronutrients powder. You can see the pictures. The powder has 12-gram content with soybean powder and macronutrients. You can put it into the homely family-made complementary foods such as porridge and noodles. And here is the formula of the Yangbao. It can be very complicated, and this one is a simple one. You can see the products contains nutrients like protein, vitamin A, D, B1, B2, B12, folic acid, calcium, iron, and zinc. And the manufacturing process is not complicated. You just purchase different raw materials and mixed in some machines, and then you packed it. But these products needs good facilities, good workshop conditions, and very strong measurement abilities. Yangbao as a complementary food supplements used for the infant's nutrition intervention undergoes 3 phases. The first phase is from 2000 to 2005, which is a scientific and technology study phases. And then second phase is from 2005 to 2012, which is a period that we're scaling up the project into more regions, into more poverty regions. And the third phase is the national project phase. That means the government use Yangbao as a national strategies for the micronutrients deficiency intervention and stunting interventions. There are varieties of studies for the Yangbao intervention and approaches that should be suitable for the poor rural regions. I'm not going to go all over the studies, but three of them I should talk a little bit about. The first is the initial project, initial intervention studies that was conducted in Gansu provinces that covers 5 counties. The result is very positive for the nutrition intervention. And the second one is the infant nutrition intervention with Yangbao in Wenchuan earthquake rural regions. That you may remember in 2008 there is a disaster earthquake that damage in many regions. So the government used this Yangbao as a tool to give an intervention on the infants from 6 years old to from 6 months to 23 months infants, which covers which covers 8 counties, more than 30,000 infants was benefit from this intervention. And the third, some benefit result, the effect. You can see the Yangbao can promote growth and development, and its benefit for the children's development scores and IQs, and also the disease burden, and also the cost benefit is quite high. You can see 1 to 10. the time comes to the 2012, the government uses the initial this project as a national project. You can see some pictures here. This is the meeting. This is the firstly 100 counties and in 10 provinces are covered. And you can see year by year the coverage increased from the beginning in somewhere about 86%. In 2018, it reached more than 90%, and also the compliance in the beginning is a little bit low, but then it's going better. And here we have a project monitoring, so you can see some information from the monitoring. You can see the project from the very beginning. It only covers some counties, and then it's going scaling up quite quick, and then this is now the project covers more than 800 counties. Each year it covers more than 2 billions of the infants. There are quite a lot of activities, campaigns, trainings, and education projects was conducted in the project. So this is my presentation. Let's take effort to promote the nutrition of the infants. Thank you very much.
Thank you very much to Dr. Siti as moderator. Good afternoon, ladies and gentlemen. I would like to special thank you for President of Federation Asian Nutrition Society, Bapak Professor Dr. Intje MS, and dear distinguished speaker. Okay, the title of my presentation is Success and Failure Factors in Controlling Micronutrient Problems and Stunting in Nusa Tenggara Timur, Indonesia. The content of my presentation are health profile of Nusa Tenggara Timur, success factors, failure factors, and conclusion and recommendation. Nutritional profile of NTT province. NTT is one of 34 provinces of Indonesia, located in southeast of Indonesia, known as an archipelago province with a long dry season, high prevalence of poor families, high infant mortality rate, stunting among newborn infants, and high prevalence of stunting, but decreased significantly. Iron deficiency anemia of NTT. Ladies and gentlemen, up to now, there is no available data for anemia prevalence in NTT. However, scattered studies show that is 25 up to 60% among pregnant women. Coverage of iron tablet supplementation for pregnant women is lower than national data. In 2018, the coverage of iron tablet supplementation in NTT was 61.67%, lower than national coverage 90%. The more likely, the nutritional anemia problems among pregnant women is higher than national average. Coverage of iodide salt in NTT province is lower than national average. Data showed that in 2017, iodide salt consumption for NTT 75.8% was lower than at national data, 92.9%. NTT province still have problem with iodine salt consumption. High prevalence of stunting, but decreased significantly from 2013 to 2019. The local government unit of NTT province has committed to decrease stunting prevalence to 10% in 2024. Success factor. Ladies and gentlemen, supporting factor that create the success story of NTT province to decrease stunting prevalence and increasing micronutrient intake are strong central and local policy and commitment on stunting, convergence and capacity building, clear priority, location and target groups, health facility and service, therapeutic feeding and feeding center, role of posyandu and community, role of women leader via local women movement team, roles of religious leader, roles of agriculture and food security, roles of higher education and professional organization, and roles of UN agency and NGO. Ladies and gentlemen, in this slide showed how all sector and institution develop at networking. Example, local government unit and NGOs and UN agency roles, the role of community, women and religion leaders, and the role of higher education and professional organization in convergence action. So that convergence mechanism is all institutions and organizations unite their strength and function focused on activity and program in targeted area and family, targeted household and individuals. First, the first 1,000 days of life. Second, school children. And third, care teenagers. Convergence has three effects. First, behavior change in food consumption and clean and healthy life pattern. Second, household empowerment to meet their need of food consumption. And third, adequate nutrient intake for the family. Failure factor. There are several factors that cause failure in micronutrient and stunting program. First, food taboo. Second, poor knowledge of nutrient and consumption pattern. Third, poor consumption of animal food, fruit, and vegetable. And fourth, lack of water supply and poverty. Fifth, some districts of food insecure and vulnerable. Example, long dry season and poor irrigation infrastructure. Fifth, access to clean water is still a serious problem in NTT, but getting better. food taboo culture. First, protein source like eggs and fish. Second, vitamin and mineral source, vegetable and all kind of nuts. Poor food consumption pattern. First, food are not various. Riskesdas 2018 data showed 82% preschool children only consume 4 out of 7 recommended kinds of food. Second, the food quantity consumed is not met with the need. Third, food consumption frequency 2 times per day without breakfast. Regular consumption of vegetable and fruit. Example, cassava leaf, pumpkin sprout, papaya flower, banana if available, annona if available, and mango different on season. Poverty, low income per capita, monthly income less than regional minimum wage, low education attainment, more than 25% of the population are under poverty line. Conclusion and recommendation. The first conclusion, main success factors are strong central and local policy and commitment, convergence and capacity building, clear priority location and target group, and stakeholders collaboration. Second conclusion, main failure factors are lack of water supply and poverty, lack of nutrition knowledge and practice, food taboo, as well as low program coverage. Third, increasing family income may take time. However, effort in improving nutrient intake can be done in short term through family resource management and nutrition education. Recommendation, strengthening water supply, sanitation, irrigation, as well as agriculture and food security development based on local resources. Strengthening roles of women and religious leaders for a better nutrition knowledge, food practice, and culture. The last, continuous and better convergence action of local stakeholders in the key to control all nutrient problem in NTT. Next. Thank you. Welcome to NTT, the region with a unique handmade movement and ecology from Eastern Indonesia. Back to moderator. Thank you.